to help us discuss this very important topic, we have our very own Dr. Suilanji Sevile, and the co-presenter for this is Madam Judith Mzeichi Makukula from Ministry of Health. And to assist us in our discussion as well, we have experts in the field. We have Mr. Mpanji Siwingwa. We also have Dr. Priscilla Mlenga and Mr. Powell Chonga. So we all know that viral load monitoring is very crucial in the management of people living with HIV. And WHO recommends the use of point of care testing in viral load management. We know that Zambia, under the Ministry of Health, has been utilizing point of care viral load monitoring in special populations such as pregnant and breastfeeding women as well as children. So today, as we discuss this, allow me to welcome Dr. Suilanji Sevile, the National HIV Technical Advisor, to take us through the first presentation, and then Madam Judith Mzeichi will take us through the second part of the presentation. Dr. Sevile, are you ready to take us through?
Yes, I am. Can you hear me, moderator?
Yes, Dr. Sevile, you are very loud and clear.
Good afternoon, network. It's happy to be here again. Apologies, I'll not be able to turn on my video because we had challenges with internet, so I need to maintain the bandwidth. Otherwise, always a pleasure to come back on the EcoPro platform, discuss issues pertaining to our program and issues where we would like to perform even much more better. So this afternoon, we will discuss the use of point of care testing for viral load monitoring and EID testing in Zambia, that is exposed early infant diagnosis testing in Zambia. So this eco session is sponsored by CEPHID, where we saw some of these point of care testing platform. There was supposed to be a slide, which I think was omitted, to acknowledge their support. And also the CEPHID team is on the platform. I think one or two should have connected, and they will be reaching out to individuals on the call to see if you can subscribe to their network so that you get technical information and other information directly from them, and they can give advice to how to use some of these platforms. Yeah. So otherwise, as a program, our desire working with the lab team is to, as you all know, to ensure that our viral load coverage is above 95. Obviously, we aim for our suppression rate above 95, where we are now. We should be, all of us, aiming at 100%. And we are also aiming that, as you know, turnaround time should be below a week now. We had put it at 2 weeks, but we want it to be earlier. But most importantly, it would be nice if a number of these test results could be received even same day, especially for certain critical populations that we are going to discuss this afternoon. Next slide. Yeah, so we will look at what the recommendations are for viral load testing and the schedules, just to remind everybody. We will look at the priority viral load testing using POCs. This is the subject matter of discussion this afternoon. We will discuss early infant diagnosis. We'll also look at the technical issues that Madam Muzieche will come in. So one of the motivation for us to have this session is because there is a change to the GeneXpert cartridges, things that might not be so conversant with. So we've allowed the technical people to take us through those changes. Next slide. Yeah, so as you know, viral load testing is our primary monitoring method for HIV treatment in Zambia. Yeah, a number of you should know that previously we used to use CD4 count, but now viral load testing is the primary, the most important monitoring method to see if the ART treatment is successful or not. And from literature, viral load testing is the most important predictor. Viral load suppression rate or being undetectable is the most important predictor of patient outcomes above all other else, above CD4 count, above having OIs or other patient parameters you should be you can have. So I usually emphasize that effective ART treatment should be given early and at appropriate time because viral load suppression is the most important predictor of outcome. It's something that will tell us whether this patient is going to live or not, or is going to do well or won't do well once we've started the ART treatment. So viral load testing simply, in a simple definition, it measures the HIV viral copies which are present in a sample, and this obviously means the amount of virus which is in blood per particular meal in the peripheral blood. It will not measure the amount of HIV virus which is in certain sites like the brain, which is a little bit excluded or secluded from other compartments of the body. And the goal of ART, as we all know, is to have that virus suppression. And mostly we want it undetectable, not just suppression, not only below 100. The goal is really undetectable. And that undetectable state should be sustained. And as I say, durable suppression or undetectable state is associated with long-term treatment success and is the most important predictor of the success of ART treatment. Yeah. So we also know that viral load suppression rate or being undetectable does mean that there is zero opportunity for transmission. So the most important pillar for reducing incidence in our HIV programming or our desire to control the epidemic is to really reduce that community viral load, the so-called treatment as prevention, so that the incidence in the population can reduce. So we like almost everyone who is with the virus should be undetectable so that there is zero transmission in the community. And thus we will control our HIV epidemic as per our vision 2030 to have the zero incidence in the country. Next slide. So we all know the monitoring schedule. You start at 6 months after commencement of ART, then at the 12 months, and thereafter yearly. That is our algorithm for the general population. For pregnant population and breastfeeding, it's every 3 months. And for those that have high viral loads who are in ESC, we know it's 3 months. And also, we do have baseline viral load, which is not probably the discussion for this afternoon. But you can see that undetectable is at 20 for our population, and this makes us happy. Anyone who is not within that category should be given some enhanced form of DSD models, but these individuals should be given enhanced adherence. We have data that shows that low-level viremia, which is between really 20 and, or other people put it at 50, depending on your machines, and 1,000 is a predictor of unsuppression rate over time. So it's a red flag or a sign that things are not entirely correct. So some measures should be taken before disaster strikes. Yeah. Next slide. Like I've said, for children and breastfeeding, for pregnant and breastfeeding women, it's every 3 months, and we want that viral load, which is 4 weeks within before EED expected date of delivery. This is one particular indicator that we are struggling to even pick. I remember last week we were looking for it, we couldn't find. We hope that at facility level, you should be able to collect, especially individuals working in MCH or maternity. We want this indicator because it is a predictor of outcomes. As you all know, we want everyone to be suppressed at that point. Next slide. So now we've also said that viral load testing, apart from routine, should be requested for everyone who is in admission. And we had quantified for this in the last 2 years. We haven't picked some data to have an understanding of how well we are performing on this particular issue, but it has got a strong linkage to our AHD implementation, where individuals that are acutely sick and are in admission, apart from making sure that the AHD screening with the CD4 count is done, would like their viral load status to be confirmed. There are several advantages. Obviously, there's clinical inpatient implications of how that individual is going to be managed. But most importantly, is the subsequent linkage to services that will optimize ART therapy. Think of it as this person has already, especially, we know that individuals that get to have low CD4 counts are unsuppressed, get into HD and get sicker. These are individuals who people who come with HD and get admitted. Most of them are individuals that are fallen off out of care or are unsuppressed for one reason or another. Therefore, that's the opportunity to catch them and link them to optimized therapy. We have data that if that is not that linkage is not strong, post-discharge rate is very high in individuals post-admission with advanced HIV disease, to a tune about 24% and readmission about 40%. We see that in several other clinical trials that we are doing. So we want to emphasize that at that point, when somebody is admitted at the district hospital, at the wherever admission is taking place, at a zonal hospital, a viral load status, if the patient doesn't know, it needs to be confirmed while they are in admission. If they are unsuppressed, linkage and efforts to optimize therapy should begin at that point. We shouldn't delay. That's how we are losing these individuals who have advanced HIV disease. And so this is a good opportunity to use our point of care test for those facilities that don't have in-house molecular high throughput machines, because you will be able to urgently, quickly get that viral load test and manage that individual properly. So this has been quantified for in the last 2 years, like I stated. Next slide. This is just some old data. We picked the year that ended last year because this year hasn't ended. We can see that by and large, we are doing well. And this is DISA information, so it's different from patient level, but we are doing a lot of tests for viral load. We are improving. We need to do better. This year, I think we've reached so far 1.5 or they are close to that, as many tests. So it's just to congratulate everyone. But you can see that for our coverage, we are still falling short of what the target should be. Next slide. Yeah, this is just similar slides. We can see age groups of suppression where we are not doing well. I think this is not new information. So what does this information mean? This information means that first, coverage should improve in those populations, but monitoring should also be more strict in these populations. So here, it's the young ones, by and large, below the age of 15, but most importantly, those below the age of 4 are the very small ones. Again, you see the adolescents not doing too well in suppression. And so what we are saying that these populations should be prioritized for point of care testing for viral load. Some of these populations, you can actually use DBS viral load testing. I'm sure the experts, the technical lab individual presentation is going to talk about the use of DBS as collecting a collection for samples. We've also allowed in some programs to have community testing where the samples are collected when visits are done and these people are being traced, especially for these populations that are of interest. We will not achieve overall viral load suppression if we do have, because these populations are pulling the whole team, the whole group down. So again, children and adolescents are priority populations. Next slide. Now, this is old data. I think this year, I'll skip this slide. This year, we know that the data looks a little bit different, but we know that it does shift from province to province. We are aware that I think Luapula needs to do slightly better, though, again, the caveat here is this is proxy viral load, not from FAO. From FAO, the results are different. So maybe we can skip this slide. Of course, this is this year's data, and we are looking at coverage. You can see where we are, not doing too well. We need to do better. Next slide. This is 23, sorry. We were still at around 82. I think the latest data should be around 87, somewhere there, but we all know that our target is 95%. So we are still way behind. Next slide. So talking about PMTCT, next slide. We still have some positivity. We can see there 6%. The figure is still the same. We can see that it's falling, but not where we want it to be, and some fluctuations. I think what we are trying to say here is as a program, we have no reasons why we should still be having this positivity. We know that a number of them come from obviously seroconversion, but we still have a portion which comes from mothers that are not suppressed. And recently, I think a week or so, we were discussing this issue. We reached out to facilities, and what we learned is actually retention for our pregnant women is lower than what we thought as a program. We are losing women for various reasons who are during antenatal not being retained. So those are the issues that we really need to work on. You need to retain them in care. You need to make sure that they are being tested for viral load, and most importantly, that peri EDD viral load is suppressed. Next slide. And this is just the testing. We are doing better, just to show some of the numbers. Next slide. You can see suppression rate, not where I would like it to be. And we've just picked some data points. The data might have changed now. Next slide. I think this slide I'd mentioned it. I'd alluded to it. Next slide. Yeah, so for pregnant women, we can see, like I've said, the indicator of viral load suppression at that peri-EDD. We do not have it in the program. We've looked for it. Colleagues from facility, you can advise if you do collect it, would like it to be collected, and you would advise how we can go around that, as we are constantly trying to improve our programming. But you can see that probably we need to do better, all of us, in PMTCT. I think so. The data shows that we need to test these pregnant women. We need to have them suppressed. We need to monitor them well for us to reach where we would like to be. Pediatrics, next slide. Again, we had alluded to this, that we are probably not where we would like to be. Yes, suppression rate is not as bad as case finding, which is in the 70s, suppression rate in the, but it's behind definitely the adult compatriots. We need to monitor children better, and we need to use better technologies for them. Next slide. This is just showing some of the trends for specific population, regions. Next slide. I think those of you who've been with us know that we've interrogated this data. We've asked provinces to present. The data from provinces shows that they're saying we are doing better. Maybe most of this data is at a central level. Next slide. But this is all data. EID testing. Next slide. So we have different platforms: conventional point of care, GeneXpert, and MPIMA. We've split the testing volumes. We want to improve here. You know that it's critical to have that early diagnosis for children so that they are put on treatment, and EID on point of care is our strategy. Next slide. Because the clinical action is critical. And also, last time we had this presentation, we did air that it's not only it's not only clinical action, but there's also a psychological, aspect to it, where you don't want a pregnant or a mother whose child is exposed to be, have her test done, and the result is not given in weeks. Anxiety remains. All of us, whenever we have a test done, we want the results there and then, so that we know whether we are positive or not, or whatever, whether if it's other tests, malaria or whatever, we want the results to be known. It's really not unfair for our recipients of care to have them wait in suspense for their results for EID. Next slide. So this is just our performance for 6 weeks. EID, you can see that not doing where we want it to be. Maybe we can go back to that previous slide. You've moved it a bit earlier for me. Yes, you can see here. Yeah, those that are having tests under EID coverage, it's a jigsaw puzzle, or is it ups and downs? So questions remains to all of us. How can we do this better to improve? This is the data we have. Of course, like I've said, facilities usually say, no, the data is different from what we have. Would like to hear comments from you. How is your 6 weeks EID coverage? You can see centrally, we think for this year, the last 12 months or so, around 66%. And this is the big population that gives us at the end of 24 months of those unknown. And it's been difficult to even push for other things like elimination, at what application, if our data is showing something like this. Just shows that these tests are not the children's results are not known, and the presumption is those who are never tested are actually also positive, some of them. Next slide. Yeah, so we have some successes, but you can see that we are not doing well in terms of our performance. Yeah. Next slide. And this is what we can do. We are going to, there are several issues that are coming up. No power, what? It's understood, and this is what we are trying to do. But some of these problems were there in our performance before power, and just shows that we, at facility level, this presentation is really speaking to us clinicians that we shouldn't lose these babies. We need to look for them. The test should be done and should be documented. Like I've said, there are so many debates about the data, the accuracy, everybody refuse, but this is what we have, and this is what is reported, and it doesn't look too good. So if data quality, it's at facility level, we need to do well. If it's demand creation, we are not doing this test. It's us at facility level to make sure that we do these things. Even those of us in main ART clinic, you see, we need to take an interest. This is our core now to what is happening in MCH. Yeah, you just can't say, no, me, I'm the ART in charge. MCH is none of my business, but you are still overseeing all HIV services at that particular facility, whether a mentor, or from a particular implementing partner, and also facility in charges. I think we need to pay attention to what happens in MCH. It's not the first time we're making this call. We need to adhere to it, and we see that these indicators are changing. Next slide. Yeah, so this we know, challenges that we have. Now we can add electricity, other things that we have. Yeah, and especially those that have to do with the conventional platforms, challenges, but there's been market improvement. All of us know that, but now we are saying, let's look at maybe how we can use point of care tests as well. Next slide. Yeah, so our communication has been clear in terms of policy. I think this memo, all of us saw it. It's an old one, an emphasis to use point of care tests for certain population. We are now telling you that we have expanded. Those who are hospitalized should be considered. Older adolescents, meaning those 15 to 24, those on who needs a baseline viral load as well, where possible, should be considered as well. Next slide. I'm seeing comments on PMTCT coming on there. That's good. We'll discuss them. Yeah, but our clear target is that I think our team from the lab will communicate to say that we'll confirm, but the plan is at the very least 15% of our tests should be done on these point of care platforms. Next slide. So I think at facility level, there is this debate or apprehension to say, if we start doing these other tests on the same gene expert that we have, do we have space? Because the TB people, the HPV people, the EID people, the viral load people, and now I'm sure in future we will also think of hepatitis B on the same platforms, and the platforms can do all other things in future, ESTI testings and things like that. It just makes sense as we are going into the multi-pathogen testing era where one platform is testing for everything. There's apprehension whether the space on that machine is adequate. And this has been the evolution to try to see that the space is adequate. So the implementation has taken a long time to migrate or to start using point of care platforms, started in 2019 up to 2024. And so a DNO, diagnostic network optimization assessments have been done, actually 2 of them, to just see whether these particular platforms are sufficient. In a nutshell, the results show that we have a lot of space. So if there are some challenges at facility level, then they are actually not because of the machines, it's human resource or how we just divide ourselves, but this work can be done according to the assessments. Like I've shown there, I think in future we need to start thinking of using other testing at other diseases, especially there's a big move from syndromic management for STI to have some form of molecular tests for those as well, including hepatitis B, which we are very close to making sure that is being done. I think further communication will be given. But in a nutshell, this is the tests. This was the next slide. You can move to the next slide. Yeah, so this, in a nutshell, it's just to show that there is capacity, available capacity to accommodate priority HIV testing on GeneXpert. I'm sure the people who are very familiar with this, the lab people, will give more information, especially Judith, who spearheaded this test. Next slide. It shows that if that is done, we will improve access per kilometer. You stop all the movements. There was an economical evaluation as well at the DNO. So there are a lot of benefits. Next slide. So I think we didn't want to go deep into that, but what I wanted to say is at facility level, at management level, local level, those our district, the hospitals who have these GeneXperts, we know that we have space. We can improve viral load coverage. It is cheaper. Suppression rates can go higher because of if we use these platforms. And indeed, as you would expect, turnaround time will improve. Next slide. And this is just some impact that has been noted as well. Next slide. Yeah, I'm sure some of these slides will be repeated by the subsequent presenter. Yeah, to just say how many facilities are doing this, what's the turnaround time, and how we've performed. I'd asked Judith probably to speak more to these slides, and I hope she has them in her presentation. Next slides, we can run quickly for the sake of time. This was the performance 2023. You can see that we are doing well. At least we are testing on these platforms. This is just the tests for EID, TB, and viral load on GeneXpert. You can see there is some improvement. This is where we want it, how we want it to be. Next slide. Quality assurance, I might not be well qualified to mention this. I think the lab individuals are on the call. They will give some meat to these slides. But what we wanted to say is really there is a question of, of the performance of these tests. We feel they are good enough. The tests were done, but let's not overuse them for adult diagnosis. We feel there's that temptation. I get those calls a lot. No, these patients, there's a discordance and so on. So can we do a viral load to prove that there is HIV? No. So this is not the correct platform for that sort of tests, especially the viral load, because if the viral loads are lower, so on, the tests might not be, the performance might not be that accurate. Yeah, so they're not confirmatory tests. We know it's something that we, at some point, maybe it's us program where we had alluded something like that when, scaling up our baseline viral load, but they're not chiefly used for that. You need the correct platforms for diagnostics. Yeah, we do have as a program a lot of cause of discordant tests, especially now those also that are on Kabele. Yeah, so for not probably the correct tests. Next slide. This is just on quality. Like I've said, the lab colleagues will give more information on this. Next slide. Yeah, so from us clinical angle, in summary, we need to remember that viral load monitoring is the primary method for HIV treatment monitoring and the predictor, the best predictor of success in HIV treatment for our recipients of care. We still need to think of how we can simplify this monitoring by using a lot of POCs and making the access to the test better. We have populations that we have quantified and forecasted for this, and these populations, pregnant and breastfeeding women, children, adolescents, those in ESC, and those intra-admission should be considered for this testing. We need to continue with demand creation, especially you can see in our PMTCT area where we still need, we have a lot of work to do. Thank you very much. Request that we proceed probably to the other presentation by Judith, then we'll have some questions and discussions later. Thank you.
Thank you so much, Dr. Seville, for that wonderful presentation. I must mention that every time I listen to your presentation, there's always something new that I learn. And I hope the network have learned one or two things. Personally, I have learned a lot of things from your presentation. For those who joined late, we had something in the presentation talking about viral load testing for all people living with HIV who are admitted. I think that's something new that all of us must ensure that we are doing. Let's prioritize viral load testing for older adolescents and young people 15 to 19, as we saw from the presentation that we are not doing well in this population as well. And the viral load testing for pregnant women every 3 months and the 4 weeks before the EDD. So those are some of the highlights from the presentation. So we'll proceed to the next presentation by Madam Judith. Judith, just confirm that you are on the call and you are ready to take up the next presentation. And then we'll come back to some poll questions. Judith?
Good afternoon. I'm here on the call and I'm ready.
Okay, thank you so much. So you can control the slides from your end.
Okay. All right.
Okay.
Thank you so much for having me. And thank you, Dr. Seville, for at least covering most of giving background to the presentation. So with what Dr. Seville has shared, I will now just add or share with you the changes that have happened to the cartridges that he had mentioned, and also just to show you why, to give you a background on why we had to actually adopt this new cartridge. So the two point of care platforms that we have in Zambia is the GeneXpert and MPIMA, which we use for EID. And I must mention here that most of our lab staff, they prefer the GeneXpert as opposed to the MPIMA because of the throughput with PIMA, it's one sample at a time, but with the Gene Expert, they can do they can run 4 samples at a go. Then also priority viral load, which we are doing on the Gene Expert, and Dr. Seville has shared on the Gene Expert. So in January 2024, we wanted to see how or to be tracking the performance, our testing performance, both for the EID and the viral load for the priority population, because as much as the tests were being done, we needed to know how are we performing towards the target. In the previous presentation, it was shown that the ratio is 40 to 60. That is for EID, meaning that 40% of the EID is supposed to be tested on the conventional platform, and then 60% of it is supposed to be done on the point of care. Then for the priority viral load, we had actually said that 70% of the pregnant and breastfeeding women viral load should be done on the Gene Expert. But for all the priority groups, the target we had said should be 30% of the total viral load tests to be done. So those we got these targets from the program, and then we did a split based on what I have explained. And so for EID, it meant that we needed to conduct 113,400 EID tests on the Gene Expert. And for the priority viral load, we needed to test 167,982. So you've noticed something we needed to, because we are already in November, almost December now. And if for EID, as it is right now, because this what I'm showing you, this is as of October, we are at 30% of our target. And for priority viral load, we are at 26%, meaning that we will not manage to actually hit even somewhere near 70% of our target. So quite a number of questions or issues were raised, trying to figure out what was causing this low uptake of these two for the point of care testing. So we had to look at the issue of capacity. If it was an issue to do with capacity, do we have capacity in the country? And I'm glad that Dr. Seville already showed a slide that shows that we do have enough capacity in the country to take up this number of tests on the Gene Expert. And the other one that we had to look at was, is it these low numbers that we are getting, is it an issue of low reporting rates? And you can see from this slide that actually our reporting rate has always been above 80%, apart from August, where we had actually 75% of our facilities reporting on the tests that were done. So now, if it is not an issue of capacity, we do have these, we have capacity on the Gene Expert machines, and it's not an issue of people testing and not reporting. We have people, we have the lab, they are reporting the tests that they are actually doing. So then what next? Where are we missing it? That is where we now came up to two issues. Number one was the issue of demand creation, which Dr. Seville has alluded to. And secondly was the issue of the sample type for EID. So for EID, so here I'm just showing you that in case you might be thinking, okay, yeah, maybe a lot of the samples are going for the conventional. So this speaks to the type of sample. So for the priority viral load, we have 29% being tested on the point of care. So remember, I mentioned that priority viral load, we said 70% of those are the pregnant and breastfeeding women. We've now included the adolescents. We have the children there. And also those are clients who are on EAC. They are all supposed to make up the 70%, but only 29% in that group are actually accessing point of care testing. It is the same picture with perfect, they've moved. It is the same picture with the EID. Sorry, I was still on the EID. So for EID, this is where we want 60%, or we want the opposite of what we are seeing right now. So we are seeing more of the EID testing being done on the conventional platform. And when we checked, this is where we now got the insight that it was something to do with the sample type. So majority of these samples that are going to the conventional platform are actually the DBS cards. So the old card cartridge. If we look at even the type or the people that do get these samples from the infants, I'm told those they are more comfortable to actually prepare the DBS as opposed to getting the whole blood. And also the other thing that we notice is that with the DBS, it goes as a set. It has everything. When you are going to do a DBS, you have your lancet there, you have your card, and it is easy. Once you collect your sample, you prepare your DBS, and you are good to go. But when it comes to whole blood, we do have our vacutainers, which are always moving, which do not move as a pair with the lancets and the other things that you will need to actually use. So when CFED did actually announce that they had now worked on their cartridge, that it is able to accept the DBS, it was quite exciting for us as a country, and we quickly did our validation and adopted the new EID cartridge, which they call the XC. So here, as of 20th November, this is our stock status. So we are currently stocked out. This is for we are currently stocked out of the old cartridge. That is the one which is currently in circulation. People still have them in their facilities. And I must mention that we have actually received this the new XC cartridge, which was showing that the next shipment, it is now on its way. It should be almost in Zambia, and so we are good to go. We have the XC, and things are going to change. Then for the viral load, we do have enough stock in Zambia. This is at central level. This is not at facility level. So facility level, we do have all the facilities. Majority of the facilities, they are well stocked, and some of them are even overstocked. So we are encouraging that facilities should actually quickly actually redistribute or share these cartridges, the old stock, so that we can start using the new cartridges at the same time. So this is where we are. So be assured that we are not stocked out as a country. So now the way forward, that we have now adopted this new cartridge. And some people are asking, so okay, so why did you adopt it? What was the rationale? So I'm just going to share with you some slides that we did adopt from CFED on the product overview. So I will concentrate mainly. I'll just pick out I will pick out a few issues which are of concern to this meeting. And yeah, so like you have seen here, it is the sample types. On the sample types, we have the whole blood as well as DBS. We can use that, and the time to results. For the whole blood, it has remained at 79 minutes, and the DBS is at 91 minutes. And when So what happens is that when the sample is negative, actually there is an early assay termination, which is the EAT. So for whole blood, it's at 63 minutes and DBS is 76 minutes. So if the sample is negative, it will not proceed up to 91 minutes. At 76 minutes, the assay would terminate and it will give you that results. So the workflow is that sample is added directly to the cartridge, which is a plus for us, looking at the type of facilities that we have out there, where I've said that sometimes the distances that these samples have to move to go to these testing hubs, they are too long such that they cannot move the whole blood, but they would rather move, well, the best sample type to move actually is the DBS. So when these DBS samples, they get to the facility, they will be able to actually test these samples for us. So here are the two differences. With the old cartridge, which we are currently using, it had a single target, and with the new one, it is a dual target. There is an addition of the polymerase there, which makes it a dual target. Then the other big news for us from the lab side is that it is GTC free. So it has been a very big issue or challenge. Okay, why is my? I thought my. It has been a very big challenge for us from the lab side because getting rid of the waste management for GTC is very difficult. These cartridges have to be actually incinerated at temperatures above 1,200 degrees Celsius. And when we started implementing this program, we did not have any of our incinerators going to that temperature. So they were being moved to go and be incinerated at Chilanga Cement in Chilanga. But now that thanks to our partners, each province now has one facility which has this incinerator, and it is able to take up this. But it is good news for our facilities because then we do not have to worry about moving our samples from wherever we are to the provincial lab. Then the other addition is that it's used for all populations. Before, the old one was just for the children, but this one, they've included all populations that can use actually this cartridge, which also speaks to what Dr. Seville mentioned, that with Zambia implementing Kabele, this is good news for us because then we can actually now confidently use this cartridge to check if people are actually HIV positive. Then it has been simplified. The DBS and whole blood method or procedure has been simplified, and it has maintained the issue of it being near patient or point of care use. And we still need to use trained healthcare workers. And before, remember, it was very clear that it was for laboratory professionals or specifically trained healthcare workers. Now, the good news is that even in places where in high volume PMTCT facilities, we can actually place this, the gene expert and these cartridges, and the health workers working there, as long as we train them, they'll be able to actually do the EID testing. So the objective here for them changing this cartridge or upgrading it is that to increase the strain coverage, the HIV-1 strain coverage, simplify the test process for health workers, and also the issue of the age. I'm sure quite a number of countries were asking them about the age, which age group can we use the EID cartridge on. Now, this is just a simple workflow on how easy it has become. So we do have our the you need the 100 microliter, the venous whole blood or the capillary whole blood. You can use either of them. It is the same thing. When you have your 100 microliter of whole blood, you directly transfer it to your cartridge, and then you load it in the machine, and voila, you wait for your results. And now for the DBS, it is shorter. Before, when you have your dry blood spot card, we needed a thermomixer, which you needed to process this sample, and then that's when you can now put it in the cartridge. But now that has been taken care of, is we just have to, from the card itself, when you receive it, you directly transfer it into the cartridge, load, and just wait for your results. So indeed, this is great news. It is now fast. It's now a fast, simple process with no need of pre-treatment of the DBS. So if you, those of you who are very conversant with our labs, you will notice that we only, out of the 245 labs that Dr. Sivide showed that were actually activated for EID and viral load, we only had about 30 of those who had the thermomixers, which is like a drop in the ocean, because then what do the other labs use for DBS? They didn't have the thermomixers. And these same 30, majority of them, they were in the defense force facilities. So now, and we all know the numbers of people that go to those facilities are not as many as they go to our other, allow me to use the word, public facilities to do that. And now this is the viral load. Viral load has also been upgraded. They've also changed it. And with the viral load is that they have, the GTC has still remained in the viral load. The time to results is 91 minutes. So that is what they have actually changed. And in comparison to the old cartridge, is that it is now also dual target. So when you have a dual target, it makes it, it improves the sensitivity, so which is good for us. And with the same viral load, we still have to use the trained professional users or health workers to do the test for the viral load. So with viral load, I must be quick to mention that the GTC is still there. So these ones, we still need to, in terms of waste management, we still need to take them to the, actually to the provincial incinerators for incineration. And so that that care still has to be taken. And I do not know if our facilities, which are outside the lab, will be able to handle the GTC. So for now, we will keep this still as we investigate how we can maneuver. If we want to start thinking of going to place it in places where there is no lab, how do we then manage these GTC waste? But otherwise, for the EID, we are so happy as the lab staff that it will be able to reach more facilities where even if there is no lab there, because they have made it truly a point of care tests. You do not have all these complications that come with these other big platforms. So the need for them to upgrade the viral load to XC was that they needed to increase the coverage of the HIV-1 strain detection. And yeah, the objective was just to broaden the strain coverage and improve its performance. This is the workflow for the viral load. It has also been simplified. You collect your 5 ml of whole blood in a serum tube or EDTA plasma tube, and then you centrifuge. So we still, just like the conventional platform, VL testing, we still need to centrifuge. So I guess you now understand why I was saying that with viral load, it's not yet at a point, at a stage that we can take it to the lowest level, where, because we will not find some of these pieces of equipment. And then once you centrifuge for 20 minutes, you then transfer your sample, and you transfer 1 ml to the cartridge, and then you run your test. Then you report your results based on what you actually see on the screen of your machine. So this has been simplified, and it is very good it's very good news for us. So this is what I wanted to share with you. This is speaking to what Dr. Seville was talking about, that if with EID, please send us more of those EID samples. Send the DBS now. I'm sure the clinicians are also happy that the turnaround time, because with point of care testing, the beauty or the advantage of point of care testing is that it reduces the turnaround time. We have seen actually with the point of care testing that our turnaround time for the lab, for those tests that are being done at the facility where there is the gene expert, it's actually 1.8 days. And then for those facilities, the spokes that are sending to a gene expert site, at the EID TAT is less than 4 days. I can say an average of 3.5 days, which is good or excellent compared to the TAT from on the conventional platform, which we are getting, which is ranging from, I've seen that the best performing province has 9 days for EID, and we have the least performing has about 15 days. So now compare the 3 days to 9 days, or 3 days to the 15 days, which is 3 days is still actually the better than those ones. I'm sure even if any of us was taught to say, I'll give you money on or 3 days from now, we'll be very excited. But if we hear 15 days from now, it won't be as exciting as it would be if we were promised to get something in 3 days. And also we hope that with this now, the mothers or the recipients of care, all those people, they will actually benefit, they will see the need for them, they will actually be accepting to have their samples are collected or to be bled, because they know that they will receive their results in good time, as opposed to how we have been trying to manage. So my final comments or words to the platform is that we have the capacity, and also that we now have these improved cartridges in country, and we hope that come January 1, everybody would have used the old commodity, we would have used it up, and then we can start accessing this one. So we have actually deliberately withheld the new cartridge because we want to first utilize what is in the facility. I've shown you the advantages of the new cartridges, and people might stop using the old one in preference for the new one. So in order to manage our resources, because those are resources, that is money that was spent to procure those cartridges that are in our facilities. So let's prudently use the resources that were spent, or the cartridges that we have. And once we use those, and we shall be able to actually then start using the new cartridge. So this is the good news from the lab side that we thought that we should share. We have already shared it with our team in our multi-disease TWG, and we thought that it was a good idea to actually come and share it on this bigger platform. Thank you very much, and over to you, moderator.
Thank you so much, Judith. That was very good news indeed. very exciting. I can't wait for 1st January. I'm looking forward to see the uptake of the new Gene Expert cartridges for EID as well as viral load. I thank you for understanding the healthcare workers, and not only the healthcare workers. In some of our facilities, we have CBVs supporting with the collection of blood for EID. So you find these are not trained in phlebotomy, and it has been a challenge. With collection of whole blood being a challenge, DBS has been the only option for such facilities. But with now the point of care EID, we are assured of 95% EID coverage at 6 weeks, because the healthcare workers or any other providers that is collecting samples for EID will comfortably collect the DBS and collect the results within time. Thank you so much, Judy, for being the bearer of good news on today's tele-echo session. I hope that the facilities will be able to utilize the stocks that are there, so that come 1st January, we are all using the new cartridges. So we'll go back and just do the poll questions from Dr. Sevile's presentation, and then we'll invite questions. I also have some questions in the chat. But I have experts on the panel. Please do help us respond to some of the questions in the chat. So I'll share the polls so that we can just, we only have 3 polls. Okay, thank you so much. So the polls have been shared. The first one is, which of the following recipients of care are eligible for point of care viral load testing? Dr. Seville did take us through. The first one is pregnant and breastfeeding women, children under 5 years old, EAC retest samples, inpatients, ART ROC admitted with unknown viral load. So inpatient ART recipients of care admitted with unknown viral load, and baseline viral load samples. So here, this is multiple choice. You can choose different answers. Which of the recipients of care are eligible for point of care? So far, we have 23% of the network participating. Please do participate in the poll. We're just trying to assess if people were paying attention during the presentation. So I'll give it a few seconds before we can close the poll. At least if we can go to 50% of the network participating, then we'll end the poll. So we'll not be able to know who has voted what. So please be comfortable as you participate in this poll. Who is eligible for point of care viral load testing? Okay. And there we are. We have hit the 50%. So Dr. Seville, this is how the network has polled. 29% are saying pregnant and breastfeeding women are eligible. 20% are saying inpatient ART recipients of care admitted with a non-viral load. Children less than 5, 19% of the network, and EAC retest samples at 15%. Others are saying baseline viral load at 8%. Your comments on this response, Dr. Seville?
Thank you, moderator. Yeah, so gratifying to see that it's the lecturer who's gotten 70% today. Yeah, so the answer is all of the above. Yeah, we would like you to consider all those populations as priority for viral load testing on POCs. Yeah, I think the session was clear on that particular point. Thank you.
Thank you so much, Dr. Seville. We'll have our second poll. Okay, so our second poll has been launched. GM, a non-ART patient receiving treatment at Senama Clinic in Mansa, which has a gene expert machine with a high viral load post-EAC. What is a preferable platform for the repeat viral load testing? Is it A, point of care viral load testing does not improve adherence to ART? B, point of care viral load improves the emotional well-being of the recipients of care? Or is it C, point of care viral load testing does not improve viral load suppression? So GM, a non-ART patient receiving treatment at Senama Clinic in Mansa, which has a gene expert machine with a high viral load post-EAC, which is a preferred platform for the repeat viral load testing. So far, we only have 24% of the network participating. Please let's participate. Okay, so I'll be closing the poll. Okay. And there you have it. Majority of the participants on the network, I think B is a correct response. Point of care, viral load improves the emotional well-being for the ROC. Well, if you, about 28% feel point of care viral load testing does not improve viral load suppression rates, and about 18% feel point of care of viral load testing does not improve adherence to ART. Your comment, Dr. Seville? Dr. Seville, are you still on the call?
Yes, so there was a bit of an error in transposing the poll on the chart, but nonetheless, the question is correct. So an individual will forget what the answer, will ignore what the answers that have been given because they didn't speak to the question, the options. Yeah, I think there was just an error in transposition. But what we were trying to assess here is really that an individual who is admitted, living with HIV in a facility that has a gene expert like Senama, yeah, that individual, and at post-EAC, they come post-EAC, they need a viral load. What is the appropriate testing platform? So the testing platform should be a POC. I think that's what the question should have said. Yeah, so what is the preferable platform for the repeat viral load testing? So for facilities that indeed do have the gene experts, the preferred repeat viral load testing platform should actually be point of care testing platforms. We can go to the next poll. I'm sure the answers for the next poll should be the ones which should have been for this poll and vice versa. I think there was some transposition issue.
Yeah.
Next slide. Yes.
Yeah, so just noted that I'm not so sure we should proceed because of the mistake that was there. Maybe at this point, I would like to invite questions, but before that, I have a number of comments in the chat. There was a comment from Patricia concerning PMTCT. So in PMTCT, there's no coordination in terms of follow-up between ART clinic and ANC visit. That's happening in most facilities. So so for the 4 weeks before the 4 weeks viral load before EEDD is missed. Same with the EIDs. Facilities need to work on coordinating ART clinics and MCH well and follow up on the program. Yeah, so Patricia, you're very right. We need to make sure that we are coordinating between ART and MCH if the client is seen in the 2 clinics. However, in some of the facilities, we have ART integrated in MCH, so the patient doesn't have to move from ART to MCH. They'll be receiving the ART services in MCH. So here we want to make sure that there's continuity of care and the pregnant woman receives all the care under one roof. There was a question from Peter Singogo, Police Clinic in Ndola. Dr. Seville, what's your comment on self-transfers? Are they supposed to do viral load on receipt of such clients? So you receive a client who's a self-transfer. Are you supposed to do a viral load on such a client? Okay, let me read another question and then you can respond. Okay. Okay, the other questions I think are for Judy. For now, I think Dr. Seville, you can respond to that question. Should a patient who comes as a silent transfer be subjected to viral load on point of care?
Yeah, that's a difficult question and a tricky one. I don't know what the platform would recommend, but we didn't quantify for silent transfers to have an extra viral load done. The assumption is that these are individuals who are in care elsewhere, and at that point when they come in, some history of some sort is elicited. If you look at the IHAP form, because for silent transfers, you still open the IHAP form, I believe. You do get the list on when somebody was diagnosed and so on, how long if they've been taking ART and that sort of thing. So you should be able to tell when was the last viral load in those individuals. Yeah, if they were suppressed, you can actually get that information. If they were due, you proceed and continue with their care. If they were not, you do give them a date. If at all they are now becoming permanent at your facility, you follow their usual schedule. And that is because we always discuss this, that the best and viral load shows that pretty much most of our silent transfers are actually suppressed. They are doing well, they have medicines and so on. So there will be no need to do those confirmations. Yeah. Unless the history suggests that this is a person who's actually a defaulter, just restarting treatment and they've been off treatment, that sort of thing. So probably you give them an earlier date. Yeah. It really depends on been in stable care and they do have been taking their ARVs. Yeah, so that can be assessed on individual by individual.
Thank you so much, Dr. Seville. Before I allow Mr. Chileshe to ask his question, Judith, there are some questions in the chat. I'm kindly requesting that you respond to them. There's a question from Brian Msonda asking, is there any waiting time after adding the DBS in the cartridge before loading? And then there's another question concerning the stock status. What's the current stock status of HIV test kits as ZAMSA, as some facilities have low stocks and utilizing self-tests, okay, HIV self-test in OPD from Bridget Mwape. We also have another question. Does it mean that for post-EAC viral loads done on point of care with repeat viral load and suppressed, we can straight away send for genotyping, skipping the conventional PCR? Then there's an issue of stock out of DBS cards in Mchinga province. What's the stock status at central level? So I will request that Judith and Panji, if you can respond to these questions concerning DBS viral load test kits, as well as what you need to do to the DBS before you load in the expert machine. Mr. Chileshe, you can proceed with your question.
Thank you very much. I hope I'm loud and clear.
Yes, you're loud and clear. You can proceed.
Okay, thank you very much. My question that is that there are a number of times when some of these facilities where we are faced with stockouts of dried blood spot cards. But when we request from the labs, from our mother labs, they advise us to use those that have expired if we have in our facilities, like the current situation in my district. So my question is, for how long can you use a dried blood the spot card that has expired, and how does that affect the results of the same card that has expired that will be used? Thank you very much.
Thank you so much. So Judith, as you respond to that question, please also try to respond to the question on the stock out of DBS cards in Mchinga province. Dr. Sivili, maybe you can help us respond. If a patient is post-EAC and the viral load has been done using the point of care with a repeat viral load unsuppressed, can we straight go away to genotyping without conventional PCR? Judith?
Thank you very much. So I'll start with the stock status for the DBS. And I did indicate in my presentation that we do have 2.2 months of stock in ZAMSA, meaning that each province that is stocked out, you need to order, you need to get these commodities from ZAMSA. They are there, they are readily available. So please do get in touch. Then I also, there was also a question on how long or time, how many minutes do you need to wait when you put the card in the cartridge? So the question from Brian. So Brian, when we are ready to start using these cartridges, we will send out the SOPs, and we will also do another echo specifically for those who are doing the testing to show how to actually do the testing. So at this stage, we do not want to start sharing that information for fear that people will now start confusing the old cartridge, which is there, and start handling it as the new cartridge. So it is deliberate, but when the time is right, we will definitely send out the SOPs and also do a training for all our people who do the testing. Then there was also a question on the capacity that there are some new viral load gene expert machines. I don't know if it's the machines or the cartridges, but the question mentioned machines. So there are no particular or specific viral load gene expert machine. It's the same gene expert machine which does the TB, EID, viral load, and HPV, and any other test that they have recommended it for. So the only difference is in the cartridge that you are going to use. And in terms of capacity, yes, majority of our gene expert machines, they are 4-module machines. And for the high volume facilities, we are always recommending that you increase the number of shifts. And once you increase the number of shifts, you are actually increasing the capacity or the number of tests that you are able to do in a day. So if you are able to do, let's say it says you can do 12 samples in an 8-hour shift. If you are going if your machine is going to work maybe 16 hours or the whole 24 hours, that means that you've already gone above 40 samples that you can do in a day. So that is the strategy that we are actually encouraging facilities to adopt. And on the issue of I saw another question that I've lost it.
Judy, there was a question as we wrap up on the expired DBS cards. After how long can the facility utilize expired DBS? Because sometimes they are told they should collect samples using the expired DBS. and what's the impact on the results that are obtained using these expired DBS cards.
Okay, from what we have been discussing is that we should allow, the only allowable time from expiry is 3 months. After that, definitely your results are going to be affected. And if you have noticed, that is why we are always trying to make sure at all times that we have DBS cards available in ZAMSA so that our people do not use expired commodities. So please do not exceed the 3 months for us to really say that we are able, we are okay using a DBS a card that is expired more than 3 months. We need to do some verification or some sort of validation to show that its efficacy is still intact even 6 months after expiry. Thank you very much. I'm sure those are the questions that were directed to me. Thank you so much.
Thank you, Judy. There's one question in the chat. Please respond in the chat. We are at 16:01. I would request that at this point, Dr. Seville can give his remarks. And as you wrap up, Dr. Seville, people saw the memo that was released in 2022. However, we saw that the uptake of the point of care viral load for the children and the pregnant and breastfeeding women was not optimized. Will there be any memo to follow up to give the providers guidance, especially emphasizing the new priority populations that need to be prioritized on the viral load point of care as you wrap up?
Thank you so much. Yes, so the memo has already been done and it has been sent out to the facilities. So thank you for this feedback. It's an indication that it did not reach everywhere that we intended it to reach. We shall reshare it and so that everybody can have access to it. But otherwise, the memo was already done and it went to the provinces indicating which are the new priority groups that we have included on the VL. Then there is also a question on the need to do software upgrade. Not necessarily. And so when the cartridges, the box, there's always a CD, a software on the CD, which the facilities just have to run and you do the test. Thank you so much.
Thank you so much. As we wrap up, I would request that Dr. Seville, you can give your final remarks. I'm not so sure if any of the experts on the call would like to give 1 or 2 additions. But we are already at 16:03. Dr. Seville, your last words to the network.
Thank you, moderator. There's a question on a child who's failing. I asked Mr. Ian Chilema to send me a text on WhatsApp. We can discuss this case as we normally do. 0977-430-210. That's my number. You can do that. And then we discuss this. Thank you for this consultation. And thank you for coming on the chat. And I'm sure most of the things we've said are clear. I'll request the question on proceeding to genotype to be answered by Mr. Mpanji, who can give his remarks in view of time. Mr. Mpanji, over to you.
Mr. Mpanji, are you on the call to give the last remarks?
Or maybe he's not. I don't know if he's still on the call, but the question was on whether if post-EAC on POC, it shows that the viral load is still high, do you proceed to genotype? Yeah, the answer is yes. Yes, so you just proceed and do a genotype if that be post-ESC. And most importantly, you also put the person on effective ART as we always advise. Yeah, thank you very much.
Thank you so much, Dr. Sevili, for the wonderful session. Thank you so much, Judith, for the insight on the new cartridges. We are looking forward to this new innovation that will really help us improve our EID coverage as well as performance, and also the viral load coverage and suppression among the pregnant and breastfeeding women, children, and adolescents. Thank you so much to all the participants in the hub. I was with Chatonda as our IT coordinator, and from the hub, would like to thank all of you that stayed on to the end of this call, and we look forward to another fruitful discussion next week. Thank you so much. For those that are asking about the link, please download the iEcho and register. Once you are registered, you are eligible to receive a certificate of attendance for every session that you attend, and you can use the certificate to get your CPD points as you renew your license for the next year. Thank you so much. Have a lovely week ahead. Bye.
Bye-bye, Dr.
Thank
Victoria.
you.
Thank
Bye.
you so much. Bye.
Bye.
Pause.